My pleasure. Okay, I just have to keep, got it, right? Sorry about that. So we just learned to share a website here. So it's just, it took me 2 years to learn this. So bear with me with the difficulties in technology. But thank you for your time, just spending a little bit of your lunch break with us. So today's, it's just briefly and very casual. I just wanted to talk about why is it important to have a PCP? What does a PCP does? And I'm pretty sure that you've heard the term. I'm like, okay, so what does that mean? That means that I'm going to see a nurse, I'm going to see a doctor, or what, what's the objective of my visit when I choose a primary care physician, and what is their job and what is my duty as a patient when I go and see one? Um, so first we're going to start with some definitions. So today we're going to talk about what's the healthcare, what is a primary care provider, what is the duty of the job of the healthcare provider, the goals of both the patient and the provided within itself, the fact that there's a multidisciplinary team that work together in order to provide the care for each and every single one of our patients. And most important, I think this is the main takeaway point, the shared decision making. The fact that, when we meet our patients and our family members, it's not a paternal relationship, is we just facilitators of the care, and we provide options. And finally, I think this is the little topic that is most interest to most of you, I think, is the healthcare screening. Why do we do the things that we do? Why do we care about screening for lung cancer or breast cancer, colon cancer? What age should I be tested and all those things? So we're gonna tap a little bit about that. First, let's do some definitions, some kind of dry material here about what is primary health care. And essentially it's made universally available for all individuals and families in the community by means acceptable to them in their full participation. So what does that mean? Means that we don't gather in a fancy building necessarily to make it really inaccessible to patients. We make it in a casual, rather organized, clean, easy access to the transportation into their community to facilitate their coming in and out of it. And the fact that we pay attention to the costs that the community and the country has to maintain that level of care to obtain an objective. That's the fancy definition kind of explained with the whole healthcare organization. And if we go in, there's multiple of them. So basically it's a place where our patients and the community within itself gets care and access to care. Healthcare centers offer professional medical care for individuals based on our locality and the community. Again, for instance, We Health Texas, we just opened our 18th clinic. So we are throughout the whole Texas, 20 miles around within the 1604. And actually we have one in Bernie and one in Schertz now, but we provide most of the services to the San Antonio local community. It forms the vital aspect of the country's health system and immensely assists in the socioeconomic development of the community. It is well known, especially in third world countries, that the first line of communication that, for instance, the government has is with the healthcare, because we see what is needed in the community. For instance, if there is lack of water, if there's lack of food in one particular area, we have the duty to report these to the community and the politician and whatever is the official person in the county in charge of providing those things for the community. And you as patients, where you tell us what you need, and we try to communicate that need to the pertinent persons in the government. We provide quality of care and cost effectiveness relationship, meaning we don't do just things because, we do things because it's gonna cut the cost in the future, and also because it will provide quality of life for our patients. We don't order tests, the CT scans, MRI, just because we wanna find out something. No, is it gonna change our management? Is it gonna make my patient's life better? not just because. The duties of the provider or the primary care providers is education, as I mentioned, about the concerning prevailing health problems. For instance, in the last 2 years, we learned, both patients and doctors, we learned a lot about COVID, how to fight it. We promote food supply and proper nutrition. I don't know if you're well, but we, Health Texas, we work a lot with the community, and we have certain activities, especially for the elderly population, with food trucks and mercados and the little clinics. And we see what the community is needed, and we try to provide that adequate supply of safe water and basic sanitation. That sounds like a third world country, but we also should be involved in knowing if our community getting clean water. Maternal child care, we don't do GYNs or OBs here in Health Texas, but we provide most of the adult care. Immunization against major infectious disease, as you will know, flu, tetanus shots, shingles shots, all of those things. Prevention and control locally endemic diseases. We provide education, safe practices, and we also practice those practices that the government imposed on us in the CDC. And provision of essential drugs. So that's mostly on third world countries. You know, we provide them from a third world country. So we have clinics that we provide free medications that are subsidized by the government. For the community here, we have samples, and obviously, depending on your insurance, we provide a prescription for you, for the patients to obtain that medication per se. Now, healthcare workers, whenever we said healthcare workers, it's not necessarily the doctor. It's a nurse, also a nurse practitioner, physician assistants, midwives. And we are very lucky here in Health Texas that besides of having a really good, smart doctors here, we have an excellent group of nurse practitioners and PA that helps us taking care of our patients in the day-to-day basis. And as mentioned in the first slide, is a multidisciplinary. We don't do this by ourselves. We requires a whole bulk of people, of human resources, of community workers, of patient navigators like Jaime Rodriguez, like Jesse, medical assistants, the people that you see in the back, checking all the vitals, doing all those orders, for instance, the medical receptionist that takes care of checking the patient out, making sure that they have the appointments. The referral system, whenever you need to see a specialist who takes care of the paperwork and fax inductions, the logistics supplies. We need gloves, who provides that? So it's a whole team. The fact that I'm using a computer, who provides the computer, who provides the support? So it's a whole team. It's not only the doctor. There's no thing that we could do by ourselves. We wouldn't have a strong team behind us and next to us. So that's about that topic. Now we're going to talk about a little bit about the annual screening, but before I touch base about that, this is the most important slides right here. This is it. Essential steps of shared decision making. So whenever we have physicians, as providers, we meet our patients, it's like a relationship, right? And the first few minutes that we obtain that one-to-one encounter is the most important thing. Since the first impressions are the most important and the one that stays in our brain, like, oh, I really like this doctor, I really like the approach and how he listens to me. But this is the most important thing. Why we do the things we do, and the fact that, as I mentioned before, we are just facilitators. We are not here to tell you that you have to do X, Y, and Z. We are here to provide information about your health, to discuss with you about what's the goal at the end of the visit. What is it that we want to attain 6 months, a year from now, 5 years from now, 10 years from now? And how we're going to come from point A to point B, making decisions based on options. So we're always going to give you a few options, A, B, C. And we explain why A is better, why B is not necessarily better, and why C is not really a good choice. But we don't impose. We should not impose as the treatment, but that's a shared decision making. And I said that this is the most important part because it's a relationship that is based on trust. So first we need the participation. Obviously, the patient come to us and we communicate what the choices are. Then we discuss the benefits. The step 3, we assess the values and the preferences. Okay, well, doc, I really don't like the sound of chemo. What about surgery? Oh, well, doc, I don't want to have an MRI. I'm claustrophobic. Is there anything else that can be done? So we work those out in the visit, and we come to a middle ground and to make a decision that, again, will change the outcome and will provide quality of care. Once we step in the 4 part, the decision with your patient, you decide together the option, and the 5 is to evaluate the decision, whether or not the decision that the patient make is a valid, reasonable, and according to the goals of standard of care, right? So this is the most important part. We are not here to impose, we're just here to facilitate your quality of life. So the first cancer screening that we're going to talk about is the lung cancer. So why do we screen that? Because it's the leading cause of cancer death in the United States. It has significant prevalence. If you go through numbers, it's millions of people, I have it in the top of my head, but it's the #1 leading cause of death. Now, the earlier that we find the cause, the earlier that we find this, the better outcome. Meaning, for instance, the survival in 5 years for stage 1 is 92% versus if we find it late in stage 4B is 0%. So finding it early in high-risk patients is very important. Identify risk factors. Obviously, you heard about smoking, all these things, also alcohol, asbestos, really things that will put you at risk for that cell in the lung to have a replication that is abnormal and therefore create cancer. So we should identify those risk factors earlier and then go with the screening to see which patient will qualify for the screening itself. Knowing that the preclinical phase is very lengthy, meaning when patients come to us, unfortunately, sometimes it's kind of late because the symptoms were there, but they're really mild, or there was a degree of procrastination in coming to the doctor and talk about those symptoms. So our duty is to identify those little red flags that come in early. So who should we screen? If you see in the bottom of the screen, it says plus grade B. So let's just say that the World Health Organization and the CDC provide guidelines for us. A is really good. We've proven it. We've done studies and it's great. B is something like, yeah, it's great, but we don't have any documentation to support. But a group of scientists did a peer review. They sit down and talk about it, and they see the very few papers that we have, and they really do recommend that. And C is like, well, you might do it, you might get good results, but we can't back it up with data. That's essentially the grades that we use. So for lung cancer, the U.S. Task Force, which is what the government provides us to screen, like we go by that guidelines, is adults age of 50 to 80 years who have a 20-pack-year smoking history. I wish I can tell you how to calculate that, but there's a Google calculator. It's really effective and it's really good. You put the number of cigarettes that you smoke in a day, and you put the years and you calculate it. So the caveat is they currently smoke or have quit within the past 15 years. So it is known that once you stop smoking for 15 years, it's like you have never smoked in the past because your risk diminished to almost to 0. So it's important to stop smoking if you do earlier rather than later. Screening for lung cancer with low-dose computer tomography, like a CT scan every year for those patients that are high risk that continue to smoke and have a 20-pack-year of smoking. And then you stop screening once the person has not smoked for 15 years, has dementia, or has a health problem that limits the life expectancy or the ability to have lung surgery. For instance, I have a 60-year-old patient that have a 35-year pack smoking. And then I do the screening every year. At 63, he has a major stroke. Things happen. He's bedridden at this point. Is it feasible for him to have a CT scan of the lung every year to detect this? Probably not, because he's right now morbidly sick. His functional capacity is really low because it's more bedridden. So the likelihood for him to survive a lung surgery in case lung cancer is found is really low given his functional capacity. So that will not be a good candidate to continue to follow on CT lungs. That's an example. The good thing about this is we do have guidelines, but it's individual case by case. And we discussed that with our patients, like the decision making that we talked about earlier. The other cancer that we screen is the prostate cancer screening. Now, these, unfortunately, the slide doesn't say, but in the bottom, if you read, it says grade C. So it's like, it's good, but I don't have data. So we screen for men age for 55 to 69, and it should be an individual decision, meaning we have to talk about the benefits and harms of screening. We do the screening with the rectal exam and also with a PSA, prostate screening hormone that is secreted by the prostate. Whenever that is elevated above your age, because the older that we get, the higher number we get, and that's normal, then we refer it to urologists for a biopsy and ultrasound. The problem is that things like prostatitis or an inflammatory process of the prostate can give you a high PSA, not necessarily it's cancer. So that's why it's individual. You have to treat every single patient and discuss with every single patient what is it that needs to be done. And there is harms to screening in this particular. That's why it's a grade C, because there's a lot of false positive, as I mentioned. For instance, if I do a rectal exam last week and then this week I check for PSA, it might be high because I stimulated the prostate and that secreted a little bit more that the hormones that were not supposed to be released. There is unfortunately overdiagnosis, overcomplication. As you know, they might undergo a large removal of the prostate, and that will have side effects like erectile dysfunction or urinary incontinence. You cannot control your pee, you cannot have an erection. Those are some of the side effects of this surgery. I'm sorry, I see that there's a question. Freezing or freezes? I will have to catch the replay. Video keeps freezing. Oh, I'm sorry, is it freezing? Can you hear me, Heather? I apologize. I just saw the message. Can anybody hear me?
Yeah, we can hear you.
Oh, okay, because it says that it was freezing. I'm sorry. I don't know how to fix that.
It may be on that person's end.
Okay. I lost my train of thought. Okay, wait a minute. We're talking about prostate. Ooh, shoot. Okay. So the next one is the colon cancer screening. Again, this is kind of interesting because it has a grade A, B, and C, depending on which one. So the A is the very good, let's do it, is the adults 50 to 75. We recommend colon cancer screening in all adults. So that way we do colonoscopies, which is every 10 years if the last one is normal, or we do Cologuard, or we do FIT cards, or we do sigmoid colonoscopies, which is like only the later part of the colon, which is most of the time where we find colon cancer. Those are the three modalities. And grade B is like very good evidence, but we don't have enough studies. It's between 45 and 49. I'm finding that most people are leading towards that, and this had changed 4 years ago. It used to be 50 and above, now it's 45. In adults of 75 through 85, there's no evidence of screening because of the complications. You can have, what I call it, complications like perforations of the gut, because if you look at the mirror, you don't look as if you were when you were 20, right? So the same thing happens inside. The colon becomes more friable, more fidgety, like if you touch it starts bleeding, it's a little more delicate. So imagine putting a camera on there and causing trauma. So that's really devastating when you become a little older. That's why we don't recommend in 75 or 76 and older. That's why we stop at 75. That's for colon cancer. Let's see, what's the other? All right, cervical cancer screening. So this is for women. The U.S. Task Force has a grade A, so this is good evidence. The only thing is that around 5-6 years ago, this changed. It used to be every year. Now it's every 3 years that we do the cervical cytology, or what they call the Pap smear, or the Pap. And we start at the age of 21 to 29 years old. Also for women 30 and 65, we screen every 3 years. But when you turn 30, we can do 3 years PAPs alone, or every 5 years the PAP, which is the cytology, plus the HPV. Now, if that HPV is negative and the cytology is negative, your next one is not even in 3 years, it's in 5 years if you're 30. For instance, you're 36 years old, you're having your third PAP. The last one was 4 years ago because you missed 1 year. And now the PAP, the cytology is normal, but then the HPV came up positive. So in that particular patient, we need to repeat that HPV PAP in 6 months. Why? Because the HPV, which is the human papillomavirus, as you know, there's 18 groups of them that can preclude to cancer or transform into cancer because they have transformed the cells around the cervix. So what we do with those patients is we repeat it in 6 months and then in 1 year, because their own body is able to fight that virus and beat it and clear it out. Let's just say that that same patient in 6 months, we repeat the PAP with the HPV and everything is negative. Then the next one is, again, in 5 years, could she clear the virus? Okay, so you can either do Cocoa testing or the alone, depending if you do the PAP or the cytology. That's for 30 years and above, 30 to 65. At 65, we stop doing PAP. So that's one of the very few things about getting older being women. The breast cancer, so there's two schools, the U.S. Task Force and the American Cancer Society. The U.S. Task Force says 40 to 49, not recommended, however, you can discuss. They do really recommend 50 to 74 every 2 years. That's the right side of the slide. Now, the left side of the slide, the right side of the slide, the American Cancer Society lower the age, again, to 40 to 44 to have the options to have a mammogram early. Then after 45, instead of every 2 years, will be every year. So that's the only difference. We give the patient the option. We used to start at 50, now we start at 45. Now, the U.S. Task Force says that after 75, you only screen if the life expectancy is more than 10 years or more, or, because we have some patients like that, we have some 77, 78-year-old patients that are pretty active. They have nothing going on with them in terms of high blood pressure, diabetes, are completely healthy. And they say, hey, listen, I want to have my mammogram because if they found something, I would like to have surgery and taking care of it. Those are good candidates, but we have to have a conversation with them. Whereas the American Cancer Society, when you're older than 50, or you do it every other year until life expectancy if 10 years or more. So the last part requires the conversation, the shared decision making, and is individualized. All right, so for skin cancer prevention, it's basically behavioral counseling. We just talk with them. Your adults, adolescents, children, and parents of your children, we really recommend minimizing exposure of UV light, especially in Texas, because it's pretty hot in here. And from 6 months to 20 years for fair skin. Again, the population here in Texas is like 50-50. I used to live in Connecticut, so that was a big deal. And we used to give SPF to everybody and checking. And then the annual, you should tell your provider to actually check your whole skin, and you should be doing that at least once a year. That's for the skin cancer. For osteoporosis, the U.S. Task Force says women 65 years and older postmenopausal woman younger than 65 that has an increased risk for osteoporosis. So who are those? For instance, Miss Maria, she's 62. She fell, tripped from the chair. She just slid through the chair, and then she had a hip fracture. That's not very common to have a hip fracture after just falling from a chair, right? It sounds like that bone was not really that hard, that strong to sustain a fall like that. Well, she was a high risk, so she should get a DEXA scan to check for osteoporosis. And then every 2 to 5 years thereafter. It is approved at 65 or the higher risk that I mentioned. Another high risk is if you're taking, for instance, steroids for a long time because you have rheumatoid arthritis. If you have really bad asthma, you have to take steroids for a long time. You're high risk. So you'll be a candidate if you're younger than 65. So other things that we do not screen are ovarian cancer, pancreatic cancer, bladder cancer, of osteoporosis in men. Not because they're rare, because they still happen, but because unfortunately there's no data that supply the blood work or the screening that will validate for ones to undergo that workup without any evidence. And that's about it. I don't know if you have a questions. I'm sorry that I missed your chat question.